Hello everyone, do you hear me? If you can hear me, then please type something on the chat. And I have problem sharing my presentation. That's why I'm sending you the file. So if you want to open the file that I just sent to you, it's called ICU Masterclass AKI. You can download it and open it. Then we can go through the presentation that way. Because at the moment,
Hey, I'm sorry for the technical problems. I think you should be able to share your screen.
Okay. Is it better now?
We can see your whole screen at the moment.
You can see my screen. Oh, perfect. So I'm gonna get started. Can you see my presentation with acute kidney injury?
Right now we see your Zoom screen.
Oh, okay. Let's try something else. How about now?
I don't see any shared screen right now.
Okay.
So I would
Mm-hmm.
probably share my screen with the beginning video first.
Yeah.
Hi,
Yeah,
you can
let's do that. Yeah.
that works.
While I work on the other part. Yeah.
Sound and share. I think this should work now.
Care medicine.
Yeah, that works.
We're back with Mr. Miller, the 55-year-old patient who suffered from a cardiac arrest last week. The post-cardiac arrest protocol is finished now and the hypokinetic of the left ventricle is declining, so the dobutamine infusion was stopped. The continuous EEG showed no more seizure potentials, so we decided to extubate the patient this morning. The patient was neurologically conspicuous, with no normal reaction, and due to respiratory failure, we need to reintubate him after a short period of time, as you can see. The next thing is that the urine output decreased over the last 12 hours. The potassium and the pH value raised. We will discuss the renal case with our nephrology expert later this day. When we look on the curve, our post-cardiac arrest patient, Mr. Miller, is 55 years old. He has a hazelnut and a cat hair allergy. We can see that Mr. Miller is still receiving some medication. First of all, at the top of the curve, we got the vasoactive medication. Norepinephrine dosed 5 mg per 50 ml is still running. The current rate, as you can see, is set at 0.04. As Mr. Miller is again intubated, he's also in need of some sedation. First we got the propofol, which is dosed at 2%. The current rate is at 12 milliliter per hour. Remifentanil is dosed at 5 milligram per 50 milliliter and running with a rate of 0.08. And as you can see, Mr. Miller received some medication for the reintubation. Of course, he's also still receiving volume. The lactated ringers are still running and the current rate is set at 21 milliliters per hour. The nutrition, called Smofcabiven, is running with a rate of 84 milliliters per hour. Right here you can see all the other medication that Mr. Miller is receiving. Heparin, for example, is dosed with 500 international units per milliliter and it is running with a rate of 2 milliliters per hour. Let's have a further look on the curve. In the middle you can see the vital signs, which also can be seen live on the monitoring unit. The heart rate is about 110 beats per minute. We have the actual blood pressure with about 125/90 and we have the saturation with 93%. The respiratory rate is about 15 per minute. In the yellow boxes you can see the in and output. The total urine output is about 135 milliliter and input minus output is 1128 milliliters. In light blue you can see the information about the ventilation. It is set in BiPAP mode. The pressure is 17, the PEEP is 6, the respiratory rate is 16 and the FaO2 is set to 0.3. The current saturation is 93%. At the bottom of the curve you can find the laboratory and blood gas analysis. As you can see, many values are marked in red as they are in the reference area. Our patient got acidosis and problems with the PaCO2, as good as with the base excess and further values. For more information and the 5 basic steps to analyze a BGA, watch our video guide. Looking at the laboratory, you can see highlighted in the red that the renal function is making problems. As we already said, we want to discuss the case with our nephrology expert later this day.
Hey, I hope that worked well. We have Ivan Chow from Switzerland here today. I hope that the screen sharing works well now.
Yeah, I will try to get that working. Otherwise, I send the file to everybody. Maybe someone can download it and then share it. Or could you download it and share it? Because I can't seem to share my PowerPoint presentation.
Yes, I can just try to do that.
So it's in the chat at the very beginning. And then I will just get started. Has everyone seen the same video as the one that was shown just now? Or has anyone else seen a different video? Because I've gotten a different video before.
So the video was visible.
Yeah, okay. So I might just get started with the presentation. And if someone can share the presentation, that would be fantastic. Because it doesn't seem to work for my computer. So I'm just going to get started. So I'm on to the first slide. And basically, the video that I saw was a lady with a septic shock with pneumonia. And the video that we just saw was a man with cardiac failure who needed vasoactive support. But in any case, they share some similarity because both patients required or are needing some renal support because their kidneys are failing. And if we go on to slide number 2 or slide number 3, that's just a question. What is our general impression on this patient? So I'm going to go through the case again, just so that we're all on the same page. So if we go to slide number 4, sorry, it's a 50-year-old lady who's a bit overweight, who has known chronic kidney disease, and she was suffering from pneumonia, and she was intubated because of her lung situation. She needed respiratory support, and at the same time, she also needed renal support because of her chronic kidney failure. And in the circumstance that she's under septic shock, it wasn't feasible for her to receive her normal intermittent renal dialysis. But in the ICU setting, what was done was a...
My name is Dr. Meiser. I'm one of the senior physicians here on the surgical ICU, and today's topic...
So this was the video from Dr. Meiser. That's the video that I actually originally saw and wanted to present this patient to you. But I can just describe the case very quickly. Basically, this patient needed a continuous veno-venous hemofiltration and dialysis. And there was a hemofiltration that was set up through her femoral vein with a Sheldon catheter, which is like in the intensive care setting, a venous access where blood can be drawn from this patient. And this catheter, which is called the Sheldon catheter, which is connected to the dialysis machine. And through this machine...
I have found the video. I can play it for you.
Yes, could you play it quickly so that everyone is on the same page? Yeah.
Just a second.
Yeah.
Now you should be able to see it.
Dear students, my name is Dr. Meiser. I'm one of the senior physicians here on the surgical ICU, and today's topic is renal failure and acute kidney injury. Now, here we have a patient, a 60-year-old lady with several pre-existing illnesses. She is suffering from diabetes, from arterial hypertension and obesity, and she also suffering from chronic renal failure. This is because in the past she had been prescribed statins, she had developed rhabdomyolysis and developed acute renal injury and finally chronic renal failure. She was suffering of severe dyspnea, came to the emergency department where an X-ray was performed, pneumonia was diagnosed, and she was intubated at once and came to our ward. Here she had a severe septic shock with high lactic acidosis, and she was treated, and as she is on chronic renal failure, obviously she needed dialysis at once. Now let's look at her electronic chart. This is when she came to our ward. She was on the ventilator. She got a Sheldon catheter inserted, and already 4 hours later she was put on dialysis, on continuous dialysis. She got moderate doses of catecholamines, and looking at her laboratory values, she got a slight leukocytosis, quite a high procalcitonin, which indicates that she's got infection. She's got a very high creatinine, which is quite typical for patients on chronic dialysis. because creatinine is quite a large molecule. It's not so easily dialyzed, and urea is only moderately elevated. Her lactate values were very high at the beginning, but they went down nicely with fluids and sepsis therapy. Now we've said that this patient is suffering from end-stage renal disease and she has to go to dialysis 3 times a week. And therefore she's got a dialysis shunt on her left upper arm, which you can see here. And when you palpate it, you can see the pulsations and you can feel the buzzing. It's very important that in these patients that the dialysis shunt is regularly looked at because it's possible that the shunt is occluded, and this is an emergency situation because it needs to be operated so that it can be used in the future. Now, with our technique, we cannot use a shunt. We need a dual lumen catheter, which is a Sheldon catheter. In this patient, it's inserted in the femoral vein. Here you can see the so-called arterial line, the venous line, and an additional small line that can be used for infusions. Now we look at our dialysis machine. This patient is on continuous veno-venous hemodialysis. Veno-venous because both lines actually arise from the vein. Here's the so-called arterial line. We follow it. It comes here. There's a pressure sensor, then the blood pump, and another pressure sensor. Obviously, before the blood pump, here is a negative pressure in the arterial line, and here is a positive pressure. Then the blood goes down and enters the hemofilter from below. It runs through these very thin capillaries that you can see as white lines inside. It leaves the filter here on the venous side. Then it enters the venous chamber. Any air contained in the system would be collected here above, and it goes back to the patient through this line. Anticoagulation is performed with citrate. Citrate is in this bag. We call this regional anticoagulation because this only works inside the system and will not affect the coagulation status of the patient. The citrate comes here. There's a stripping chamber, a small pump. Then it follows in a very thin line. It follows the arterial line, and it goes until very close to the patient, and here the citrate is added to the blood. And on the other side we do calcium resubstitution. Calcium is in this bottle. It follows here a dripping chamber. This pump is turning very slowly, very slow rate, and the line again follows the blood line until very close to the patient, and here the calcium is resubstituted to the patient. Now, of course, we also need dialysis fluid. The dialysis fluid is put on top of the machine within these 4 big bags, each containing 5 liters. Then the fluid is collected here, goes through this dialysis pump, which is turning quite fast, and then the dialysis is put through this heater. It's heated up to 37 degrees, and then the dialysis enters the hemofilter from above and exits here below. It's important that the direction of the flow is opposite to the blood flow, because this will make the dialysis much more efficient. Here the used dialysate, which has taken up toxins and metabolites, is going down, entering and is collected in this collecting bag. Of course, we also want to draw some fluid out of the patient, and this is performed by filtration. So some fluid from the blood is filtered through these capillaries into the dialysate, and it leaves the filter together with the dialysis fluid here. We call this ultrafiltration, and in this patient we are getting 200 milliliters per hour ultrafiltrate out of the patient every hour. So what's the prognosis of this patient? Well, as she is suffering from end-stage renal disease, she will stay on dialysis for the rest of her life. As long as she is with us, she will get continuous dialysis because this is less aggressive, much more gentle. She has a good chance to recover from her pneumonia. Probably she will face quite a long weaning period. So the next days she will be tracheotomized, but I think she has good chances to get to the state where she was before.
Great, so we're all on the same page now. I'm happy that this video works, but my sharing is still not working, so I will refer to the slide that I've sent before. So now I'm on to slide number 4. So I'm going to try and keep this as concise as possible and as short as possible so that you get an overview of what acute kidney injury is about. So if we look at slide number 4, you see the charts from this patient. She's obviously intubated, is under vasopressor support, and you see a red arrow. That's where the hemodialysis was started. You see a red arrow in the middle of the chart that's pointing down. Exactly. If is it possible to share the slides as well, if you can? And so on the left.
No, I thought I shared the slides.
Perfect. Yes. And if you look at the left-hand side, there are the medications that she's under. And if we consider this patient who's having chronic kidney disease, and at the moment she's having also acute on chronic kidney disease, then we need to consider the medication that she's receiving. On one side, on the top, you have noradrenaline. That's going to help her kidney perfusion, right? Because she's under septic shock. And propofol, that's going to cause vasodilation, peripheral vasodilation. So it's also going to affect her kidney function if there's too much of it. And if we go down the list, there's her antibiotica, piperacillin, tazobactam. That's obviously something that she needs for her pneumonia. But however, we have to think about the doses, because obviously if she's under dialysis or she has chronic kidney disease, it's possible that she needs a reduced dosage. And if we go down, sodium bicarbonate, that's something that we give. I will go into a bit more details into that for our acute kidney injury patients, because patients who have acute kidney injury, they often have acidosis, metabolic acidosis. And one of the options that we can give is give bicarbonate to try and neutralize the acidosis, but it's not without risk, because bicarbonate obviously produces carbon dioxide. And if the patient is already having trouble with her respiratory system, carbon dioxide is obviously not good for her. And if you go down the list, there's also atracurium, which is a muscle relaxant. Atracurium is actually known for being safe for kidney patients because it's metabolized by this so-called Hoffmann degradation, which is not related to the kidney. So we can give it, it's actually a choice by the physician to give that instead of other muscle relaxants like rocuronium, because they tend to accumulate in kidney disease. So if we move on to slide number 5, so we see, as explained by Dr. Meiser, that this patient is having acute kidney injury, which is exacerbated by her pneumonia and septic shock. And you can see that her creatinine was very high on the blue line there. We're actually on slide number 5. But through the dialysis, you can see over time that the creatinine has been ultrafiltrated. So it started with 7.8, and through the continuous veno-venous hemodialysis, because creatinine is a very small solute. The smaller a solute is, the easier it will be ultrafiltrated. So let's say we have some toxins or some proteins or infection, that there are some molecules that we want to get rid of. Unfortunately, the dialysis machine, through this semi-permeable membrane, it's only able to dialyze certain molecules that is small enough to go through this this membrane. But luckily, the two main substances that we want to get rid of, creatinine and urea, which is called Harnstoff in German, that goes through very well. So patients will benefit from dialysis when the urea is very high. So if we go to slide number 6, that's just a time scale of her blood gases. We can see from the very top on the left-hand side that her pH was very low. Obviously, she's acidotic. And through the treatment that we were giving, for example, we gave fluids. We also gave bicarbonate. And through this process, and obviously with the dialysis, her pH was improving. And you can see at the second from bottom, the AHCO3, the bicarbonate, it was also increasing. But then it dropped again. If you see the 5th column, because there's several things that went through between the 4th and the 5th column. But I'm not going to go into details, but that's just to give you an impression how the dialysis has helped her, and the fluids that we gave and the bicarbonate that we gave her, how the metabolic acidosis improved. But obviously, there is a small setback, because I think between the 4th and the 5th column, she had the bronchoscopy, and there are other things that happened in between. If we go to slide number 7, so the definition of acute renal failure, traditionally in 2004, there was this RIFLE criteria. So when it goes from risk, injury, failure to end stage. So these are the stages. But to be more exact, this has been redefined in 2007, that a creatinine increase with more than, depending on your unit, 0.3 milligram per deciliter, or a 50% increase in your baseline creatinine. Or you have a reduction in urine secretion for with less than 0.5 milliliter per kilogram per hour for more than 6 hours. So often, if you are in the ICU, or you work at a ward where there's more intense observations, the nurses will tell you, oh, the patient is not producing urine. What do you do? Do you give fluids? Or do you wait? That's one of the most frequent questions you will get when you work at the ICU. So obviously the definition is 6 hours. Yeah. If the patient is not producing urine for 2 hours, then that's per definition not acute renal failure. But obviously you have to be vigilant. You have to observe the patient, how this is developing. And if we go to slide number 8, that's just different stages of acute renal failure. Like now we would use the Aiken criteria. The RIFLE criteria is a bit older. So anyone who requires renal replacement therapy, dialysis, is automatically in stage 3. So what are the etiologies of acute renal failure? So I'm on to slide number 9 now. So if we put it into a very basic term and understanding, is that the kidney can be damaged or have injury due to these 3 things: pre-renal, renal, and post-renal. That's something that you really need to understand. That's very, very basic. Basically, it means if it's pre-renal, it's the blood supply or the perfusion that goes to the kidneys that's affected. So situations such as hypoperfusion, sepsis, or hypovolemia, that can automatically cause pre-renal failure. Also renal failure caused by pre-renal cause. And I'm on to slide number 9. And if you look at the renal cause, the kidney itself has 3 areas which are of interest. The glomerulus, where the site of ultrafiltration happens. So your blood goes through this glomerulus, and at this filtration site, there's a damage to this site of ultrafiltration, where blood or protein goes through the site. So there will be a leak in blood or protein or larger molecules, which normally doesn't go through, because normally the smaller solutes go through, molecules that are such as creatinine, urea. These go through the ultrafiltration site and they get reabsorbed. But obviously, if there's damage to the glomerulus, these different proteins or blood products or blood will go through, and then automatically they will be seen in your urine, which is why patients who have glomerulus problems, such as patients who have nephritis or nephrotis, there are 2 types of renal cause of renal failure. Then you'll see blood in the urine or protein in the urine. So examples are membranous glomerulonephritis, or in children, minimal change disease. And if there's damage to the tubules, such as like crush injury, like rhabdomyolysis, where the myoglobins, which is breakdown products from your muscles, they get clogged inside the tubules. Then the tubules where the reabsorption occurs gets clogged up, and when it gets clogged up, they will start to die, which is why it's called, when this acute kidney injury happens in the tubules, it's called acute tubular necrosis. Drugs can also cause kidney problems, some of which can cause problems within the interstitium, and some of which can cause problems in the tubules. But I won't go into details how each drugs affect your kidney in that way, but it's just important that you're aware of it. Antibiotics such as gentamicin, that's a typical one. You always have to be careful because it's very toxic to the kidneys. And NSAIDs and diuretics, they can cause the kidney damage, but in a different way. But I won't go into details of that. And then the final reason why kidney injuries happen could be post-renal, which is a mechanical obstruction of urine production or urine release. So if there's anything that is starting from the calyces of the kidney down to your ureter or urethra, any obstruction on the way for urine to be produced, if that happens, then there will be a backlog of urine, and that's going to cause kidney problem as well. If we go to slide number 10, I do apologize, there are quite a few slides, which is why I try to go through the most important ones, and then the rest you can look at the file yourself. I actually sent the file on the chat so that you can download it and have a look at it yourself later. So what are the risk factors for acute kidney injury, particularly in ICU patients? Obviously, patients who are already having pre-existing diseases, such as our patient with pneumonia. She already had chronic kidney disease. I think she also had diabetes. Obviously, the kidneys are already damaged in that sense. So if anything else that comes on top of it, it's going to make it much worse. Obviously, if she was still producing urine, there's a very high chance that her urine production will be dramatically reduced. And obviously, patients who are under sepsis, patients who have medications that can affect your kidney function, they are risk factors. And patients that come through surgical ICUs, you have to consider what kind of surgery they've had. And during the surgery, there might be things that happen that can cause further damage to the kidneys. And patients who have had crush injuries, or they take statins that can cause rhabdomyolysis, and patients who are mechanically ventilated, because the intrathoracic pressure is going to affect the intra-abdominal pressure, which is going to affect the perfusion of the kidneys. That has also to be put under consideration, because our patient probably has not just a pneumonia, but a respiratory failure that required ventilation. So the ventilation that she required probably needs very high pressure. So the higher the pressure, the more intrathoracic pressure there's going to be, and also in the intra-abdominal space. Because we know the perfusion of the kidney is affected by your mean arterial pressure minus the intra-abdominal pressure. So if the intra-abdominal pressure is very high, then automatically the perfusion of your kidneys will be drastically reduced. And multi-organ failure, obviously, kidney doesn't work alone. There are other organs that work with the kidney, and if they start to fail or they have problems, then the kidney will also be affected. So if we look at slide number 11, that's just a statistic of in the ICU or critically ill patients, what are the commonest causes of acute kidney injury? So the commonest is sepsis. So And if we look at the right-hand side of slide number 11, that in a study that looked at ICU patients that have had acute kidney injury, almost a quarter of them needed renal replacement therapy. So that's a high number of patients. And obviously, acute kidney injury is associated with increased costs. More people die from it, and length of stay at the hospital is drastically increased. So what are the implications of that? That means if we as physicians, we can recognize that early, or we do the precaution, we recognize the risk factors, we can probably avoid it. So it depends on the patient population that you get, because the patient comes into the ICU, they don't tell you, oh, I've got acute kidney injury. It doesn't work like this. That's why it's really important to be aware who are the high-risk patients, what have they had, why are they coming to the ICU, have they had a major surgery, or are they already chronically kidney diseased, what is their hydration status, what is their blood pressure, what is the perfusion to the kidney. All these things have to be considered so that you can recognize potential candidates that can have acute kidney injury in advance in order to avoid further problems. So if I move on to slide number 14, that's just a repetition of the latest guideline, how we stage acute kidney injury. So if we move on to slide number 15, so we also have to consider how the drugs that we give to our patient, how it affects the renal function. Because we know that if we go to slide number 16, the renal blood flow is very, very high. It corresponds to almost a quarter of our cardiac output. So every minute, 1.2 liter of blood will flow through your kidney. Obviously, the kidney has its own mechanism to compensate for low blood pressure or high blood pressure. It's called the Bailey's effect. So if the blood pressure increases, the kidney has this myogenic response to dilate its arterioles so that the perfusion to the kidney stays the same. So the perfusion pressure of the kidney, or the blood flow to the kidney, stay constant. But if we look at the top right-hand corner, we're on to slide number 16. This autoregulation only works within a certain range. So if the blood pressure goes beyond 180 or below 80, this auto-regulation mechanism starts to fail. So your kidney will ultimately becomes affected. So if we move on to slide number 17, you can see that on the right-hand side, there's your glomerular filtration rate, which is the GFR, which sometimes you can order it in the laboratory. How that corresponds to serum creatinine. And if let's say a patient who has a baseline creatinine of 80 micromoles per milliliter, let's just say 2 milligram per deciliter, that would correspond to 120 GFR. But if the creatinine starts to rise. So we talk about stage 1. So let's say if you look at this curve on the y-axis, on the straight line, that the column, if it goes from 2 to 3, just by increasing by 50%, that's already stage 1. And just scroll that across and have a look at the GFR. You're already looking at the GFR dropping from 120 to less than 50, which means the creatinine value is actually, it comes a bit delayed, which means if you have a patient who has already an increasing creatinine, his kidney function probably has dropped more than 50%, which is why it's very important not only just to look at the creatinine value, not just to look at the laboratory, but also you have to look at the patient as a whole. What is your blood pressure? What is the urine output? In order to be alert, this patient is at high risk, or he's already suffering from acute kidney injury. So let's move on to slide number 18. It's just a case where a patient has been lying for 18 hours at her flat. She's 70 years old and she has a broken hip. If we look at the right-hand side, her creatinine kinase, that's extremely high. It started at, it's a 5-digit value. You see where it's yellow, 14,000. So this patient has had a crush injury or a injury where she's not able to move and the muscle starts to break down, so it produces myoglobin, and that starts to clog up in the kidney. So you can see that her creatinine was actually sky high, because her baseline value is 41, and when she presented to the hospital in 2016, her creatinine is already more than 4 times her baseline value, which means she's already probably at stage 2 or stage 3 renal failure. So if I just move on quickly to slide number 20. So what are the causes of acute kidney injury, and how do you diagnose it? Obviously, I mentioned pre-renal, renal, and post-renal, and the diagnosis is actually quite simple. You do basic laboratory and look at the creatinine kinase. You order urine analysis and see if there's evidence of hemoglobin, which is a sign that there's hematuria. Obviously, if you suspect that drugs are causing kidney injury, then you have to look at the drug levels, because there are obvious candidates that, such as aminoglycoside, like I mentioned, gentamicin, that is a candidate that can cause acute renal failure. And if you suspect a cause that is renal, then you have to look for antibodies that can also be an autoimmune cause. Exactly. So if I move on to slide number 23, so apart from laboratory, we can obviously, there's a way to just rule out something that is very simple, which is the post-renal cause of acute kidney injury. And that's putting an ultrasound next to the kidney and having a look if there are evidence of hydronephrosis. If there's evidence of hydronephrosis, then or you look at the bladder that's completely full or empty, then there's a reason to suspect that there's a post-renal cause of the kidney injury. If we move on to slide number 24.
Just quickly, there's been a
Yep.
question in the chat.
Yeah.
Is the BNP in the case report elevated because of a chronic heart failure or because of a renal failure to compensate the volume overload?
At the BNP, well, the BNP, BNP can be elevated in volume overload, obviously, but this patient, I don't think she has a chronic heart failure, so it could be the fact that she's under acute kidney injury and there's a backlog of volume, so she's not able to urinate, and it causes a overload within the left ventricle that caused an increase in BNP. Yeah. That would be my explanation. Obviously, I don't know the patient because I'm not there, but that could be the explanation for her elevated BNP. Yeah. But BNP, let's just say in acute kidney injury, is I wouldn't order that if I suspect a heart failure, an acute heart failure, then I would order a BNP. But if I suspect an acute kidney injury, I wouldn't do it routinely because there are other laboratory values that can show me this patient is, for example, losing protein in her urine analysis. She's having edema in her lungs, in her legs, and her creatinine is sky high. That already is enough for me to know that the cause of her edema is not a cardiac cause, but a renal cause. Exactly. So if we move on to slide number 24. So, like I said at the beginning of the this lecture, one of the signs that that patients are having acute kidney injury is that they are not producing enough urine. So there's a very good flowchart that is in the EMCrit website that helps you guide your evaluation. So obviously you want to rule out urine obstruction. So it's very simple. You just put an ultrasound next to the kidney, you rule it out. If there is a problem with hydronephrosis, then obviously you need a urology consult, or you put a Foley catheter to try and elevate the blocked bladder. If it's higher up, like a stone problem or a prostate problem, then you need to call urology. But if there's no obstruction, then you have to look further to the hemodynamic evaluation. Is it a problem with hypovolemia, or is it a problem with blood pressure where you don't have enough perfusion to the kidney, or is it a cardiac cause? If you suspect any of these, then you can do, if you look further down this flowchart, you can do a volume challenge, where if you obviously have a patient who is who's had a huge surgery with lots of blood lost, or a patient who's had a major trauma, then you would think volume challenge. You would think that then you can give volume and see if it improves with the urine output. Obviously, if it does, then it's clearly a pre-renal problem due to volume, lack of volume. If you suspect there's a problem with blood pressure, then you can try a vasopressor challenge, which is giving medications such as noradrenaline, try to artificially increase the mean arterial pressure, and observe if the urine output increases. If it does, then obviously there's a problem with the blood pressure, because obviously your kidney requires a certain amount of pressure in order for it to work. If it's a cardiac cause, then you would also give an inotrope. In this case, inotrope, it meant probably not noradrenaline, but dobutamine, which increases the cardiac function in a patient who has had, for example, heart attack or ventricular failure. And you can try these medications, because, like I said before, if one organ doesn't work, kidney is always the next organ that gets affected. Because there's this cardiorenal syndrome or there's this hepatorenal syndrome, they're all interconnected. So, and the final, on the right-hand side, if you suspect a renal cause of the renal failure, you can do a furosemide stress test, which comes onto slide number 25. Is that if you give furosemide, which is Lasix, however you call it, it's a loop diuretic, which if you suspect that the kidney is having problems intrinsically, you can give it. And if your urine output doesn't increase by more than 200 milliliter in 2 hours, then you are most likely confronted with intrinsic renal failure, which is not likely to improve with more fluids or vasopressors, because the kidney itself, either in the tubules or at the glomerulus or the interstitium, there is some damage. So it's probably unlikely to improve under the circumstances. Even if you give more fluids or more vasopressors, it's not going to improve the renal function. And probably the renal function is already lost through this damage. Okay. So we talk about acute renal failure, which is obviously decrease in renal function in an acute situation. But if I look at it in a very in a daily setting, so I have a patient who has acute renal failure. Why does it bother me? Creatinine is a bit high, urine's output is a bit low. Well, maybe they have some edema. Why is it so important? Why do I care? Patients are generally not very unwell. Like, I'm talking about setting where patient is not having a septic shock, but just a normal patient who is maybe a bit hypovolemic. Why do I care? Because these values, creatinine that is high or urea that's high, it doesn't really do much to the patient in reality. They're not collapsing, they're not but however, if it gets sky high, then the symptoms will start to show. I'm talking about high in urea, or high in fluid overload, high in potassium, and very low in pH. If these situations get out of hand, then the symptoms will start to show. The patients will start to decompensate. So how do we treat acute renal failure? I'm just going to try and wrap this up in the next 10 minutes so that I can leave some time for some question. I'll get to the point. So obviously, we try to treat renal failure according to its cause. If it's a pre-renal problem, you give fluid, you increase the blood pressure, you try and increase the perfusion. If it's a renal problem, then obviously, if it's a rhabdomyolysis, then you have to try and also give fluids to unclog the renal tubules. Or if there's a nephrotoxic substance that was causing it, then we have to stop that. Post-renal, obviously, you have to consult urology. And obviously, the treatment is guided by the complication that they have. If they have hyperkalemia, and then you have to treat that. Obviously, that's another talk, how we treat those complications. So if we move on to slide number 28, there are obvious causes for pre-renal kidney injury, which I mentioned before. And you need to manage the fluid. So if we move on to slide number 29. So if it's a pre-renal cause, patient is hypovolemic, then you give fluids. But how much fluid? That's the question. Because too much fluid, that's also going to not only affect the kidney, but also it can damage the kidney. It can cause renal venous congestion, and it can actually exacerbate the acute kidney injury. And what fluid do we give the patient? These are the questions that when you're in your daily practice, you really have to look at it every day at every single patient, because you have to assess the patient yourself. You have to look at them clinically. Is the patient fluid overloaded or not? Is the patient hypovolemic or not? And you have tools within the clinical setting to determine whether you give fluids or not. I think it's important to also look at what fluid we give to our patients, because not all fluids are good for your patients, especially within acute kidney injury. You can give balanced intravenous fluid, or you can give sodium chloride, which is saline. But studies have shown that saline is actually bad for your kidneys, because it can cause hypochloremic acidosis. The chloride load that comes with the fluid will actually cause acidosis, and the sodium load that comes with it will actually cause retention of fluid within your blood. So it's actually going to make your kidney more sick, let's put it that way. If we look at the long-term, so we move on to slide number 31. The long-term effects or middle-term effects of giving saline. If you look at A and B, that's obvious. You get sodium and you get chloride. That's obviously higher within patients who get saline. And if you look at the creatinine level, graph number F on slide number 31, that saline actually causes within 3 days a increased creatinine, which is obviously an indicator of worsening of kidney injury. And the potassium level in some ways. Yeah. Sorry, potassium, no, that was a mistake. Potassium, no. Because potassium there's no potassium within saline, so obviously potassium level will go down if you give saline. What about albumin? If we go to slide number 32, albumin is often given in situation where patients need fluids, but they're not retaining them because they're getting peripheral edema. But studies have shown that albumin is generally not very helpful in the setting of sepsis, or there is no advantage of giving albumin in patients who have acute kidney injury. Albumin obviously is much more expensive than normal saline or balanced solution. The only situation where you would give albumin is when a patient has hepatorenal syndrome. That would be the only situation where it's indicated. So I'm going to move on to slide number 39. Just to give a few examples of these cases so that it's less boring with this theory that I'm telling you. So let's have a look at case number 1, slide 39. 40-year-old alcoholic patient presents to the emergency department with confusion, melena, and he has signs of chronic liver disease. He is pale, his blood pressure is low, he has a pulse of 130, and his hemoglobin is 6.3. Gamma GT is sky high, and his creatinine is elevated. So this is millimoles per liter. And urea is also slightly elevated. Potassium is also elevated. So what is the cause? Obviously, this patient has acute kidney injury. But what would be the cause of his kidney injury? Does anyone want to perhaps write in the chat? Is it pre-renal? Is it renal? Or is it post-renal? Pre-renal. Excellent. Exactly. So the patient is bleeding from his upper GI bleeding. So he's hypovolemic. And through that, his kidney is affected. But it could also be a hepatorenal syndrome. So, which is a backlog of venous blood flow due to the liver problem as a primary cause of the kidney problem. But I won't go into details of that. Just to keep it simple, it's a pre-renal cause due to his hypovolemia. Let's go to case number 2. That's slide number 40. A 17-year-old student presents to the emergency department with a 6-day history of sore throat. And now he presents with frank hematuria, swelling of her ankles, and poor urine output. So what would be the cause? Obviously, she also has some sort of kidney injury. So what would be the cause or the etiology of her kidney problem? Is it renal, pre-renal, or yeah, PSGN? That's correct. That's the post-streptococcal glomerulonephritis. Exactly, that's a renal cause of her problem. Exactly. And let's have a look at case number 3. That's the next slide. 75-year-old presents to his GP with increasing malaise, back pain. He has problem urinating. His creatinine is sky high, urea is sky high, and PSA is also high. And conveniently, you also have an ultrasound next to you, and you look at his kidney. There's evidence of hydronephrosis. So what's the cause of his kidney injury? I'm just trying to look at the chat, but I think everyone knows that. That's quite obvious. The cause is post-renal. Yeah. Probably not BPH because he's got back pain and he has malaise. Probably it's already more than just hypertrophy of his prostate. Probably he has a metastatic prostate cancer that's infiltrating to his ureter, and it's causing back pressure to his kidney. Or this malaise could be also due to prostate infection, prostatitis. That could also be a cause. Yeah, but obviously this patient needs, what's going to kill him? The cancer or anything else that you see on this slide? It's probably the potassium that's going to kill him. So he needs an urgent treatment for his hyperkalemia. Obviously, the obstruction of his urine output has to be referred to urology, and he probably needs a scan for his prostate, probably a CT to start with, and then later MRI or bone scan if he's got bone metastases. Okay. The rest of the lecture is more about what we do within the ICU, the medications that we give. So if we move on to the next slide, 42, obviously the medications that we give to our patients, like many anesthetic agents, they can cause vasodilation and they are negative inotropes. So we just have to be very vigilant within ICU or perioperative that we have to make sure that patients are not hypovolemic. That's to start with, and make sure that they have a good enough mean arterial pressure in order to avoid acute kidney injury. And obviously, pain and stress can stimulate your central nervous system, which causes vasoconstriction of arterioles, which can obviously affect your renal blood flow and affect your kidney function. And all this hypotension, hypovolemia, is just going to be a vicious cycle because your kidney will detect it. It will then stimulate your renal angiotensin system, which causes arterial vasoconstriction, which causes reduction of renal perfusion, and obviously then kidney injury. If we move on to slide 44, 45, that's just a summary that you can look at later, how different inhalative anesthetics, hypnotics can affect your kidney. Obviously, the two main ones are halothane and methoxyflurane. These are very seldom nowadays because of their nephrotoxicity. Obviously, that's not commonly used anymore. What about intravenous anesthetics? Obviously, there are things like benzodiazepines. They can accumulate because of the renal excretion, and also medications such as ketamine. They can also accumulate in renal insufficiency. So we just have to be aware of it. And opiates so the opiates that we give in a setting of anesthesia, like fentanyl or remifentanil, they are not affected by kidney failure. But things such as morphine and petadine, you just have to be extremely careful because they can accumulate. And petadine, especially, if it accumulates, it can cause neurotoxicity and can cause epileptic seizures. And muscle relaxants, I mentioned before at the very beginning that if you know that a patient has acute renal insufficiency or acute renal injury, then you have to be very careful what you give to them. Obviously, the choice of using atracurium or cis-atracurium, they are much more kidney friendly, and rocuronium is just going to accumulate, or the metabolism of rocuronium is delayed because of renal insufficiency. Then you just have to be very careful that you don't give it, because if you give it and you try to antagonize it, sugammadex would work, but its effect would be prolonged. So if you want to relax the patient again, then you can't use rocuronium anymore. That's just some small details. And just move on to the very last bit about dialysis. So when do you decide that the patient needs dialysis? Obviously, patients who are uremic, that they're showing symptoms of it, like uremic encephalopathy, or the potassium is too high, and you give medications such as calcium gluconate, or you give insulin, and the potassium is still very high, or the acidosis is unresponsive to treatment, or patient is overloaded. You give loop diuretics and they're not really responding, or they have edema in their lungs and they're not responding, or you have patients who have toxins or things that causes intrinsic renal problems. Then you have to consider dialysis to try and save the patients. So I think within the ICU setting, obviously there are patients who receive continuous veno-venous hemodialysis, but there are also patients who receive intermittent hemodialysis. And if you really want to take something out of this lecture, I would say go to the last 3 cases that I have in the slides. That's slide number 67, 68, and 69. And just look at each patient, and obviously if you understood my lecture, then you would probably know the answers. But just have a look at those slides quickly. Patient A is someone who is critically ill post cardiac arrest, is on supported by impeller device on high dose vasopressors, and he's hyperkalemic. So what kind of dialysis would you give to this patient? Obviously, I would give continuous diafiltration, because that's for his blood pressure is much more, there's less fluctuation, and there won't be so much fluid shift. So if we use intermittent dialysis, for example, in this patient who has pneumonia, who's under septic shock, probably if we do intermittent dialysis through her shunt, she will completely collapse with her blood pressure, because these patients are not suitable for fluid shifts. And intermittent dialysis is obviously something that you need to take a certain volume from the patient, half a liter or a liter or even more, and then it gets dialyzed, and then it will get transferred back to the patient. Obviously, these patients are not suitable for that. And if you look at patient B and C, then you'll see start to get the picture of how within the ICU, how these renal replacement therapies are considered. And finally, slide number 70, you can see the advantages and disadvantages in different modalities that can help your patients with acute kidney injury. So I'm coming to the end of my talk. It's gone on a bit longer than I expected, but I hope you get some idea of what acute kidney injury is about. Maybe I will take 1 or 2 questions at the end. If anyone is still around or awake, then I can try and answer them. But I want to try and wrap up in the next 5 minutes.
So if no one wants to ask with microphone, there has been another question in the chat. Albumin is recommended in the Surviving Sepsis campaign if hemodynamic stabilization despite double vasopressors and hydrocortisone is not effective. How do you describe the discrepancy between this weak recommendation in the guideline and your lecture?
Okay, so I mean, albumin, I might just go back to the slide. I'm not sure what number that is. There's a distinction between when to give albumin. So albumin is not contraindicated in sepsis. That's correct. That's slide number 32. And the question is, so I would do it practically if I give 2 different vasopressors and the patient is still not responding. Patient is still, let's say, have fluid retention. They're overloaded, and the blood pressure is still really low. Then I would use albumin as a rescue. There's no evidence to suggest that it's going to harm your kidney in this setting, but there's no evidence that suggests that albumin is going to improve the survival of patients who have sepsis. So that's the message. You can give it. I would give it as a rescue, but obviously, if someone comes in with sepsis, they're hypovolemic at the beginning, but they have capillary leak. So you give more fluid, they leak. And the thinking behind it is also you give protein, so there's some hydrostatic pressure that keeps the fluid intravascularly. So that's the thinking behind it. But the only evidence that it shows that helps patient that you can give albumin is hepatorenal syndrome. In sepsis, you can give it. In the guidelines, it doesn't. There's very weak evidence that shows that that you can give it, but obviously the message is very mixed. In our ICU in St. Gallen, we give it, but we give high percentage, and we only give small volume. So we give it for this hydrostatic effect as a rescue. If it works, great. If it doesn't work, then we move on. We treat the cause. We wait. Yeah. But usually it's not because of the kidney. If it's not only because of the kidney. If it's under sepsis. Yeah. Good. I think there are no more questions. So I thank you all for your attention. And yeah.
And
sorry about the technical
thank you
problem
very
in the
much.
beginning. Yeah. Yeah.
I hope
for
it worked
having me.
fine. I tried to show the slides a
Yeah,
little bit while
you did
were
really
talking.
well. Yeah.
I thank you very much for the
Yeah.
well, lecture. Well done. I learned a lot, and I
Thank you
hope
for
the
having
others
me.
did as well.
Take care. Hope you enjoyed the
Then-
lecture. Okay, bye-bye.
Bye bye.